what is pleura? We know it's a serous membrane of mesodermal origin. We know it has a visceral pleura, which is adherent to the lung, and a parietal pleura, which is adherent to the which lines your chest wall, basically diaphragm and mediastinum. Its contents are basically mesothelial cells, and its main role is in fluid absorption. Normally, the fluid in the pleural space is about 10 to 15 ml, which is not usually seen on the imaging. Now, on a chest X-ray, when we talk about pleura, you would not directly see a pleura. It is basically the fissures. Now, what are fissures? We have a horizontal and oblique fissure on the right, and an oblique fissure on the left. So when these fissures, particularly the visceral fissure, visceral pleura, basically, when it overlaps and it forms these fissures, when it folds and it overlaps in an anatomical formation and forms these fissures, the visceral pleura is what is actually seen as the pleura on the X-ray. So directly, you'll never be able to see the pleura. You would always identify the fissures, which are dividing your both sides of your lung into different lobes. So in a normal lung X-ray, on a chest X-ray, you will not see pleura directly. Now, when we talk about a chest X-ray and radiological signs of effusion, they would depend upon the position of the patient, whether it's a free-flowing or a loculated effusion, state of the underlying lung. For your costophrenic angle to be blunted, minimal amount of fluid required is 200 ml. Often you would find a difference in these values in different books, but 200 ml is the minimum amount which is required. And obscuration of the hemidiaphragm requires at least minimum 500 ml. Now look at these three different chest X-rays. As you can see in the first X-ray over here on the left, there's a minimal blunting of the costophrenic angle. So minimal effusion. But again, for minimal effusion, for costophrenic angle to be blunted, 200 ml. Then this has a large effusion. There's a typical meniscus sign of the effusion. And there's an loculated effusion here, probably with an irregular margins of the effusion seen on this chest X-ray. So we all know various causes of pleural effusion, transitate and exudate. Now, on a supine film, especially in patients who are in your ICU or who have been moribund, lying down all the time, when you do a chest X-ray for them, an effusion may appear like this vein-like opacity. There would be preserved vascular markings through the effusion in this, like you can see in this X-ray on this hemithorax, and there'll be lack of course, air bronchograms will not be seen. So this is also a left massive pleural effusion, but in a patient who's lying supine. So this X-ray has been taken in supine position. Now, special types we know about: subpulmonic effusion, opaque hemithorax, loculated effusion, vanishing tumor or the pleural pseudotumor, and lamellar effusion. Now, what is a subpulmonic effusion? A subpulmonic effusion is basically when the fluid collects at the base, the surface of the lung. And if you can see in this chest X-ray, there's some sort of a reflection, extending on this right side. So now this is nothing but there is fluid collection here under the lung surface, which is known as which is what suggests that there is presence of subpulmonic effusion. Again, when you look at this chest X-ray and you look at this difference, if you can see that this funding gas bubble and the diaphragm, there's a distance of more than 2.5 centimeter. Again, this is suggestive of subpulmonic effusion, commonly seen in infections. Then, for loculated effusions on a X-ray which is done end phase, it might be ill-defined. But when the beams are parallel, X-ray beams are parallel, then it is a sharply well-marginated effusion that you can see. So loculated effusion can appear like this also. As you can see, there are multiple loculated effusions on this chest X-ray as well. Now, there's an entity called the vanishing tumor or the pleural pseudotumor. Often, if you see on this chest X-ray, you can see a thorn-like obesity through the fissure, or you can see this elliptical shadow. These sort of shadows, this sort of a presentation is usually seen in patients of congestive heart failure, very responsive to diuretics. And, suddenly the next day, you would see when you've given the patient diuretic and he's adequately decongested, you would see that these shadows have suddenly disappeared overnight. And so the term vanishing tumor or pleural pseudotumor. Then opaque hemithorax. Now, opaque hemithorax can be a massive effusion with an underlying collapse, can be a massive effusion with underlying lung mass associated. Never be in a hurry and jump in to put in a tube. Never be in a hurry to drain the fluid quickly. Always, of course, if your patient is very symptomatic and you're sure you have to, but it should depend upon the clinical presentation. You should correlate, and if you have available bedside ultrasound, you should quickly do an ultrasound. Now, again, look at these chest X-rays. You can see a large opaque hemithorax. Seen on the CT, there's a large effusion. On this coronal section also, you can appreciate a large right pleural effusion. Various causes of opaque hemithorax, pleural effusion, consolidation, collapse, massive tumor, pneumonectomy, fibrothorax, and lung agenesis. Now, another entity of pleural effusion seen on chest X-rays is lamellar effusion. Now, this lamellar effusion is also seen in conditions like congestive heart failure, which is basically accumulation of fluid in the interstitial space, basically between the lung and the visceral pleura. So, this is not a true effusion. And with the underlying characteristic history and the presentation, you can identify this. Now, uh, we've talked about X-ray. Now, presence of ultrasound these days for the last 20 years has brought about extensive use of ultrasound and pleural effusion as well. It's easy, it's readily available, there's no radiation exposure. You can describe the site and size of effusion. You can use it to identify the space from where you need to do your drainage. You can characterize, you can look for loculations, presence of any solid masses, and also look at the underlying lung. Now, this is a characteristic ultrasound picture. If you can see, there's lung over here. So this is the visceral pleura. This is the one marking is your parietal pleura, and there's this echogenic and echoic space over here, which is your pleural fluid seen in this ultrasound um, image. Like I said, it's a bedside, easily, readily available tool, helps you to quickly identify your underlying pathology, and you can do it multiple times. It can even detect small effusions, look for septations. When you look at these ultrasound um, films, and you can see this, that when you look at this ultrasound picture, I'm sorry, so you look at this and you can see that there is a normal, this is a normal pleural line. If you can appreciate this white pleural line. In this ultrasound film picture, you can see that this is your diaphragm. There is the presence of liver. And then there are these lung reflections. When there is fluid, these disappear. Remember that there is a lot of artifacts which are seen on the ultrasound, which is what forms the basis. Then in this, you can see some B lines. And, when you put the M mode, this is the characteristic normal seashore sign. So we're going to talk more about this as we go ahead in the ultrasound. Now, again, look at this film. You can see that there's a lung here, there's liver, and there's this ecogenic uh, free area, anechoic space. So this is what is your pleural fluid here. Again, you can appreciate the diaphragm, the liver, then this is your lung floating within the fluid. And again, on this ultrasound picture, you can see that there is a lot of loculations and septations, pocketed diffusion seen. So these are different presentations which you can quickly assess bedside with the help of an ultrasound. Again, you can see this X-ray and you can appreciate that there's an effusion, but look at this ultrasound images and such extensive loculated diffusions, even appreciated on a CT. Now, there are certain signs which we see on an ultrasound for our effusion. If there is a large effusion and the effusion is reflecting, sometimes you can even see the thoracic spine. Hence, this is known as a thoracic spine sign seen on the ultrasound image of the patient with a large pleural effusion. Then there is something known as a sinusoid sign, which is seen on the M mode. So basically, it demonstrates the movement of the parietal and the visceral pleura. So if you can see that there is a large pleural effusion, there's an ecogenic free area and echoic space here. There's your diaphragm over here. The lung is floating over here and in between. And when you put the M mode, then you can see the sinusoid sign over here. This is because of free floating fluid in your patient. This is how it appears. So this is a sign seen on the ultrasound. Then there is something known as a quad sign, which is a static sonographic sign, which is formed by, if you can appreciate, there's a superior rib shadow here, there is an inferior rib shadow here. So these two lines, and then there's a parietal line formed by the parietal pleura and a visceral pleural line, also known as a lung line. Again, you see there's a pleural fluid in between this space. This forms a quad. So this is a quadrant, right? 4 lines. So quad sign. Now this space can also be used for thoracocentesis. So this is another sign which you can appreciate on the ultrasound. Now, X-ray is a modality. Ultrasound is a quick, rapid, easily available radiation-free tool bedside. Then we have CT scan. Now, CT scan of the pleura, when you see, now a normal pleura would actually be, so this is a contrast CT image. And if you can appreciate this structure one, this space over here, this is basically a visceral and parietal pleura, extrapleural fat, endothoracic fascia, and innermost intercostal muscles. Then there is an intercostal artery. And in this black space over here is your intercostal fat, and then this 4 and 5 are your intercostal muscles. So this is your normal pleura that you would see on a CT scan along your ribs when there is no pleural pathology, when your pleura is normal. This is how you can appreciate it or you can identify it. Now, when you look at this contrast CT images again, over here, like we described the structure, if you can appreciate, this is what is visible on a mediastinal window. Then the parenchymal window, the lung window, when you look at it, when there is no pathology, you would see this anterior junctional line, which disappears if there's a pathology, right? So this is your normal pleura. Then again, it would depend upon the presence of fissures, the oblique and the horizontal on the right, and the oblique on the left. Then, there is something known as Hounsfield units that we've been talking about across these classes, across these sessions. And that is something that we see, which we see as an enhancement on your contrast CT. So, look at these CT cuts. As you can see over here, you can appreciate pleural fluid over here. And in this, you can see thickening of the pleura on the CT. This is your parietal, this is your visceral pleura, and you can see fluid in between. So this is your characteristic split pleura sign, which is seen on your CT thorax. So different presentations, but usually it's the underlying pathology and clinical correlation which can help you maybe suspect the fluid being transited and exited. However, specifically just based on CT, you cannot say whether it's a transited or an exited fluid. Then some more axial cuts. And if you can see over here, again, there is a thickened visceral, thickened parietal pleura, there's presence of a mass lesion, and there's fluid in between. So this is another loculated diffusion, split pleura sign. Then if you can see on this, there's a mass-like lesion over here in between. There's some nodular deposits, and there's a large effusion in this CT cut. Then this is a PET cut, PET CT, and you can see an enhancement, well-defined effusion, which is loculated. Could be an empyema as well. So different CT presentations, like I was talking about the loculated. Now this was a coronal cut from a patient who had a liver abscess, and you can see that there is a lenticular opacity over here of a loculated diffusion and elliptical one over here. Again, along the fissure, there is an elliptical opacity over here on the CT cuts, which goes to suggest that these are loculated diffusions, non-dependent locations. Then uh, we've when you've seen enhancement of the pleura, the thickening of the pleura, specifically like this, if you can appreciate visceral pleura and your parietal pleura, and you can see some white deposits across this between these pleura. This is basically thickening of your pleura, and there is enhancement. So this is your split pleura sign, which is seen in empyema. Again, on a CT, you can appreciate this is a CT sign basically, and you can appreciate over here. This was the ultrasound. This is the CT. The lung is lying collapsed. There are some air pockets over here. So these are the findings which you commonly encounter in a patient with empyema. Again, just to reinforce, if you can see over here, again, you have both the pleuras are thickened. There is presence of effusion. There's also some extrapleural infiltration, which goes to show this is your basically a split pleural sign in a patient with empyema. So this is how it appears in a patient of empyema. Now, you have a patient of empyema and the patient is not getting better, or you have to reassess or you have to reevaluate whether the patient requires decortication or not. So when is the time when you would consider your patient for decortication? When you have put in a chest tube and there is no adequate drainage, when there is thickness of the pleural rind, when there is presence of loculi, the extent of the lung, the extent to which the lung is trapped and it's not expanding. If you can see here, so this is something which you should consider if your patient of empyema and for decortication if he's not expanding. Again, cautions in imaging interpretation: never insert a chest tube without ultrasound, never be in a hurry, first of all. And then dense opacities can always be masses, so you confirm with a CT or an ultrasound. If sometimes you need to assess the lung parenchyma in specific case-based scenarios, you should do a CT to rule out. Never be in a hurry to, if you've seen a massive effusion and just put in a chest tube, which is generally done quite often. So don't do those things. Then, look at these CT cuts. How do you differentiate CT as well as chest X-ray? How would you differentiate between a lung abscess and an empyema? So now an empyema would be, we would talk on these two CT axial cuts, okay? So on an empyema, you would see that it is a pleural based shadow, and a lung abscess would be a lung in the lung parenchyma, right? Then it would form an obtuse angle with your chest wall. This would form an acute angle with your chest wall. It would have irregular margins. This would have a well-defined margin, usually smoother margins, actually not well-defined. If you can compare, they're very irregular. There would be an air fluid level, a cavitation. This would often have septations, loculations, pocketed sort of a thing that you would see over here. Multiple loculations might be appreciated. So this is how you differentiate between a lung abscess, an empyema and a lung abscess. Then again, if your lung is not re-expanding after thoracocentesis, so what could be the causes? Okay, we've talked about decortication earlier, but what could be the other causes after thoracocentesis if the lung is not expanding? There could be a trapped lung in case of malignancy. There could be a chronic empyema, a thick rind of visceral pleura, which encases and contracts the lung, or a presence of a bronchopleural fistula. Now, there's a direct communication with the airway or lung parenchyma and the pleural space, right? And this bronchopleural fistula can occur in cases of trauma, surgery, or even necrotizing infections, as you can see in these both CT cuts. Then another entity which has come up and is, evolving more and more in case of pleural diseases is MRI. Now, it is usually used in cases to characterize complicated effusions. Uh, Type 1, the hyperintensity, there are T1 weighted images, T2 weighted images, and diffusion weighted images, right? So normally there is a low attenuation in T1 weighted images, which is dark black, right? Like if you can see your, normally your parenchyma, lung parenchyma is low attenuation, right? But if it becomes hyper intense on an MRI, then it could be a case of chylothorax or a subacute blood accumulation in your pleura, which would become hyper intense on T1 weighted images in MRI. Then there's another thing which is called diffusion weighted images, which we often hear neurologists talking about on CT heads, MRI head. So this is basically restriction of diffusion because of high cellularity. Now this is seen, if you can appreciate in this cut, there's a very high intensity image. Now this is commonly seen in cases of empyema and malignancy. So again, MRI more in complicated effusions might be helpful in a chylothorax or in cases of a hemothorax. Uh, Empyema, and even in certain cases of malignancy. So it will be the diffusion weighted images and the T1 weighted images, which would help you to identify your pleural based lesions in MRI. Now we've talked about effusion. The next entity that we commonly come across in the pleura is your pneumothorax. So what would you look at in a chest X-ray? You would look at the pleural line, which is white. You would look at absence. You would look for absence of vascular markings. And look at this chest X-ray. So this is a typical right-sided pneumothorax. There's an underlying collapsed lung as well. So another X-ray showing you a tension pneumothorax. Then look at the X-ray on the left. If you can see here, I don't think anybody can appreciate a pneumothorax here. Sometimes there's a doubt. And if you have a doubt like this, then in that case, you can do an expiratory film. And, as you can see over here, in an expiratory film, you can appreciate the pneumothorax. So when there is a doubt, you can do an erect chest X-ray during in expiration. and that lung density will increase, and you would be able to appreciate, like I showed in the previous slide. You can do a lateral decubitus with the suspected side raised. You can do ultrasound, which is the easiest and readily available on your bedside, and it help you identify very quickly. And in some cases, if required, a CT scan as well. Now, this is a CT appearance of a pneumothorax. There's presence of subcutaneous emphysema as well. Again, if your patient is lying supine, looking at this X-ray quickly, you'll say there's nothing. But if your patient is in the ICU and is lying supine all the time, do not forget to look at your costophrenic angle. Do not forget to look for the deep sulcus sign, which is commonly seen in patients who are lying supine in cases of pneumothorax. So always remember, don't be in a hurry and say that, okay, this is a normal CT, normal X-ray. So always look at the costophrenic, always look for the deep sulcus. Again, in a supine patient, we look for deep sulcus. There'll be increased lucency. If you can see, there's a lot of subcutaneous emphysema on this. There's a sharp hemidiaphragm. There's a continuous diaphragm sign also, which is normally seen in cases of pneumomediastinum, as there's a lot of subcutaneous emphysema also in this case, in this patient. Another entity that we see is the hydropneumothorax. It's a characteristic air fluid level. There's loss of bronchovascular markings. There's a pneumothorax, and there's a collapsed lung lying here. Then something that we often want to differentiate when we talk about a pneumothorax and how would you differentiate it from a bulla. There's absence of this is an X-ray with a pneumothorax on the right side. There's absence of bronchovascular markings. There's a sharp convex border. The underlying lung is lying collapsed. In case of a bulla, you may or may not see bronchovascular markings, but this is a well-defined, thin, concave margin, and this is a right bulla. If you're not sure, you should do a CT, and you should confirm. So as you can see, in another patient, there's a bulla that is seen on the CT. Then often, when you have a patient and you think that he's developed a sudden pneumothorax, you should always remember mimics. Do not forget. Always look at your film systematically. And, especially in elderlies, you can have skin folds. You can see bronchovascular markings, some calcifications even through this. So don't be in a hurry and jump to a conclusion that this is a pneumothorax. If you have a patient who suddenly gets a shadow like this and there was nothing yesterday or even in the morning, then always re-examine, examine, clinically correlate. That always remains the mainstay. And then, of course, if you have an ultrasound, quickly put the ultrasound on the right side and look for it. So, you'll be able to rule out pneumothorax. Now, talking about ultrasound per se, it of course has sensitivity more than your supine radiographs. Sick patients, ICU patients, very helpful. Presence of lung sliding rules out pneumothorax. Even presence of a single B line also rules out pneumothorax. Now look at this, these two ultrasound images. This is done in M mode, and when it is a normal lung, you can see the seashore sign. But when there's a pneumothorax, you can see there's a typical barcode in the M mode or the stratosphere sign. Now, in case of pneumothorax, the common things that we should know on ultrasound are the absence of lung sliding, lung pulse is absent. One single B line rules out pneumothorax, so B lines should be absent. A lines can be present because they are normal pleural reflections. Lung point may be present. So now look at this normal lung sliding. If you can appreciate, this lung is normally sliding, right? This is the normal lung sliding, and if you can see here, there is no lung sliding. And when you put it in the M mode, you can see the characteristic stratosphere barcode and the seashore normal. So this is what is your lung point, which differentiates the normal lung from the area where there's a pneumothorax. You can see that this is pointing towards the area where the probe has been put, and you can see the absence of lung sliding over here and the lung sliding here. This is what is the lung point. Now, what is a big pneumothorax? Now, British Thoracic Society has guidelines and American Thoracic Society has guidelines. So when you look at this, you would if you can appreciate this collapsed lung, you measure this distance, okay, from the chest wall to the area of this collapsed lung. And this should be more than 2 centimeters as per the BTS, which is where you say that this is a large, big pneumothorax. Again, if you measure from the apex to the area of the collapsed lung from the chest wall, according to the American College of Chest Physicians, this should be more than 3 centimeters to say it's a big pneumothorax or a large pneumothorax. Then again, to understand the percentage of pneumothorax, various formulas. Then, like I said, that there's a collapsed lung lying in between. So you measure the maximum distance from the center of the collapsed and the maximum distance in the hemithorax. And when you put it in this formula, 1 minus L3 and H3 into 100, which would give you the percentage of pneumothorax. Various formulas are available to understand and calculate the percentage of pneumothorax. Very important from clinical point of view and for procedure point of view, triangle of safety. What is triangle of safety? It is basically an anatomical region which is used to for your ICT placement, right? And what are the boundaries? So the apex of the axilla is the is where the triangle is formed, right? So the anteriorly it is formed by the lateral border of the pectoralis major. Okay. Posteriorly, it is by the lateral border of the latissimus dorsi, and inferiorly, it is a horizontal line at the level of the nipple, which roughly corresponds to your fifth intercostal space, commonly at the fifth intercostal space. So this is what is your angle of safety. This is what you should always identify, and this is where you should put your intercostal drainage tube. Now, pleural thickening is another entity which we often come across. There is asbestos-related pleural diseases. So there are pleural plaques. There is round atelectasis, malignant mesothelioma. As you can see here, if you can appreciate, this is discrete, focal, irregular areas of parietal pleural thickening. These are your pleural plaques. This is how they appear. They don't have any malignant potential. Then malignant pleural mesothelioma is a highly aggressive tumor. Then on a chest CT, when you would look at a CT thorax, you would see that there is nodular circumferential thickening. There might be chest wall invasion. There'll be mediastinal pleural thickening. There could be a presence of a pleural effusion at the time when you do the CT for the patient. And this is a characteristic PET CT from a patient of mesothelioma. You can see that there's a great uptake in the pleural rind-like extension of the tumor. So this is how it appears on a PET CT. Then how to differentiate a pulmonary and a pleural mass? So look at this actual CT cut. A pulmonary mass, a lung mass would be, well defined, would have smooth margins, would form an acute angle. Okay. Whereas a pleural mass would be, would form an obtuse angle with the chest wall. There'll be an obtuse angle if you can appreciate on this X-ray. So that is one of the major differentiating points. Then metastatic diseases, the pleura are difficult to diagnose in the absence of a known primary. 40% are associated with lung cancers, then about another 30 to 40% with breast cancers and 10% with lymphomas. So pleural anatomy and its imaging correlates are essential for accurate diagnosis. Chest X-ray remains a useful tool, but it has its own limitations. Ultrasound is invaluable for pleural fluid detection, characterization, and guidance for thoracocentesis. CT thorax offers detailed anatomical information, detects pleural thickening, split pleura sign, and loculated collections. MRI and PET CT provide added value in complex cases, especially for trapped lung assessment for malignancy. Then for pleural effusions, look for distribution, density, loculation, use USG and CT volume estimation. Empyema versus lung abscess, we've already talked about. Pneumothorax, look for the deep sarcophagus sign on supine X-ray. Absence of lung sliding, lung point on USG, and absence of lung marking can guide diagnosis. Pleural masses, CT and PET CT help differentiate benign versus malignant pleural tumors, mesothelioma versus pleural fibroma, and always confirm pleural pathology before intervention. Never be in a hurry to just put in a chest tube. Always do prior imaging. If you have ultrasound available, quickly put an ultrasound and evaluate your patient. Always clinically correlate. Always examine the patient. Do not forget to examine your patient. Thank you.